Hello, everyone, and welcome to the Southeast Medical Advisory Council meeting. As many of you know, since 1976, the American Liver Foundation has been a trusted resource for liver patients and those who care for them. So we thank you for being part of our rich 45-year history. For those who are visiting with us this evening, on behalf of the American Liver Foundation and the Southeast Medical Advisory Council, we are delighted to have you with us. Please note that this meeting is being recorded and a YouTube link will be shared with everyone who has registered to attend. In just a few minutes, we're going to move on to the medical education component of our program. But first, I wanted to take a moment to recognize our meeting sponsor, Albireo. With us this evening are Emily Wallace and Deb Zolo from Albireo, and I'd like to give them the opportunity to introduce themselves and to speak with you for a few minutes. So Deb or Emily?
Yeah, thanks, Kathy. Thanks, everyone, for letting us join tonight and being able to have the opportunity to support this program. I'm looking forward to the conversations. Deb Zolo here. I am located in Florida, and I support Georgia, Florida, and Puerto Rico. For those of you who haven't heard about Albireo, Albireo is a biopharmaceutical company dedicated for the development of novel bile acid modulators, specifically looking at treating rare pediatric liver disease and adult liver diseases. Right now, currently, Albireo has multiple clinical trials taking place, focusing on biliary atresia, Alagille syndrome, PFIC, and other cholestatic diseases. I'm going to go ahead and let Emily tell you a little bit about what's going on now. Emily?
Thanks so much. I'm Emily Wallace. I'm the clinical account lead in the Mid-Atlantic. So that's Maryland, Delaware, DC, Virginia, North Carolina, and South Carolina. And I'll kind of pick up where Deb left off with where we stand right now. So as a result of the largest global phase 3 trials ever conducted in PFIC, Albireo is currently celebrating the first FDA approval of a once daily oral pharmacologic treatment option for pruritus in patients with PFIC, which met both of its primary endpoints. And this is the first ever approval by the FDA of a drug developed for pediatric cholestatic liver disease. For a subset of patients whose approved options previously included only surgical interventions, including transplant, this represents hope for this community. So that said, Deb and I are part of a team of dedicated individuals across the country in field sales who are working to identify and help support these unique and rare patients. Treating children with PFIC can be difficult and frustrating given the standard treatment options that have been available. The burden for these kids and these families is unimaginable. So we're actively reaching out to clinicians with the goal of providing medical and commercial resources to aid the practitioners in advancing the care and treatment of PFIC patients. If you haven't heard from us already and you have an interest in this topic, please reach out. And so with that said, I'll turn it back over to Kathy, and thank you again so much for this opportunity. We're proud to support you tonight.
Thank you so much, Emily and Deb. We appreciate your introduction. And now it's my pleasure to turn the meeting over to Dr. Viana, our Southeast Medical Advisory Council co-chair, and he's going to provide for us the Southeast MAC update.
Thank you very much. Thank you all for being here tonight with us. So I'll provide some of our updates. First, congratulating one of our Southeast MAC members, Dr. Binu John from Miami VA, University of Miami. He led a study that was recently published by JAMA on COVID-19 infection and hospitalization among cirrhotic patients. So congratulations. The Southeast academic debates will take place on October 5th. So please mark your calendars on that. It's very, very important. We have 8 institutions participating from Florida, Georgia, South Carolina, North Carolina. Dr. Andreas Zori from the University of Florida, Gainesville, and Dr. Raj Satyanarayana from Mayo Clinic. I hope I said that right. Jacksonville are this year's co-chairs. So again, I would like to reinforce those are very interesting debates that you mark your calendars for that. On October 13, Dr. Andrew Cavaney from Mayo Clinic will be the featured speaker at our next MAC meeting. He will speak about personalizing the care of patients with cirrhosis. So please mark your calendars for that, October 13. On October 15 and 16, the LF will host a patient education conference on liver cancer. Southeast Board and MAC member Dr. Ali Zaringpar served on the planning committee for this conference. And please share this information with your patients if appropriate, obviously. On November 16, the LF will partner with the University of Florida Health's liver team from Gainesville and presenting a medical education program for primary care providers in the Daytona area. And if any of our Southeast MAC members are interested in presenting an educational program for patients and providers, please let us know. It's always good to have this kind of programs. I think, that's what we're here for, to get information to our patients. And I think that was it. And I will hand the program back over to Kathy. Thank you.
Thanks, Dr. Viana. I appreciate that. As many of you know, the American Liver Foundation is marking its 45th anniversary this year, and we will be celebrating by hosting our Legacy Gala on October 21st in New York City. So far, our fingers are crossed. This will be an in-person celebration. But it will also be live streamed across the country. So you've likely received information about the gala via email, but if you'd like to read more about the awardees or purchase tickets to attend, please visit the website. It's alfgala.org. And I had mentioned that we are going to be doing some live streaming across the country. So far, we have two markets who have offered to do satellite events, one in Denver and one in Boston. And if anyone is interested in the Southeast area to explore the possibility of hosting a small live streamed, wine and cheese, whatever, certainly reach out, let me know, and I will connect you with our events team. At this time, it's my pleasure to move along and talk about our education program. Tonight's program is on pediatric liver disease, and it will be presented by Dr. Alisha Mavis. Dr. Mavis is board certified in general pediatrics, pediatric gastroenterology, and transplant hepatology for pediatrics. She attended medical school at the University of Oklahoma College of Medicine, completed her pediatrics residency at the Medical College of Wisconsin affiliated hospitals, and completed 2 fellowships, one in pediatric gastroenterology at the Medical College of Wisconsin, and one in pediatric advanced transplant hepatology at Lurie Children's Hospital in Chicago. Currently, Dr. Mavis is a pediatric gastroenterologist, pediatric hepatologist, pediatric small intestine transplant specialist, and pediatric transplant hepatologist at Duke University Health. Her specific areas of interest include liver transplantation, portal hypertension, and Fontan-associated liver disease. Dr. Mavis is also a member of the American Liver Foundation's Southeast Medical Advisory Council and National Medical Advisory Council. If you have any questions or comments for Dr. Mavis, please feel free to share them during the Q&A session that will follow her presentation, or certainly by entering your comments into the chat feature on Zoom. And now it's my pleasure to turn the program over to Dr. Mavis.
Thank you, Kathy, for that warm welcome.
Yep, I'm going to pass the torch over to Dr. Mavis in just a sec here, sorry. There we go.
All right, can you see my screen, Kathy?
Yes, I can.
Perfect. Thank you again for that warm introduction. Thank you everyone for having me. Tonight we're going to talk about pediatric liver disease, some of the more common diseases in pediatrics, kind of following right along with Albireo and the cholestatic disease. We're going to be talking about 2 of the 3 that they mentioned, and looking at the treatments and outcomes. So it's going to be kind of a bigger, broad picture overview rather than getting down into the meat of every one of the diseases. So with that, we'll move on. So my disclosures, I am on the speaker bureau for Alexion and Albireo, and I'm a consultant with the Pfizer gene therapy company. Objectives for tonight, we're going to review the most common liver diseases in pediatrics, some of the most common, I should say, biliary atresia, Alagille syndrome, alpha-1 antitrypsin deficiency, autoimmune hepatitis, and of course, we can't forget non-alcoholic fatty liver disease. We're also going to discuss the symptoms and treatments of these liver diseases, and then examine the outcome or how these diseases are treated. We're going to start right off with biliary atresia. Just so everyone knows, I do talk fast, so if you need me to slow down, jump in and say something. I don't mind being interrupted. Biliary atresia is a rare progressive disease of the intra and extrahepatic bile ducts, resulting in fibrosis and obliteration of the bile ducts. It usually presents in the first 3 months of life. These kids come out looking pretty healthy and then rapidly progress. Occurrence is about 1 in 8,000 to 18,000 live births. It depends on what part of the world you're in. But it is our leading cause for liver transplant in pediatrics. There's 4 known phenotypes as of now. These may get divided out more in the future, but right now we have isolated biliary atresia that's associated with laterality defects, including your asplenia, polysplenia, and situs inversus. Biliary atresia associated with other major congenital malformations, and then biliary atresia associated with bile duct cysts are also known as cystic biliary atresia. Etiology and pathogenesis is unknown for all of these. This is where I say we may divide these out differently in the future as we get to know more and learn more about it. There's been multiple proposed etiologies. The ones that always come to the top is perinatal viral infection, abnormal bile duct development, prenatal toxin exposure, and dysregulated immune response. So the clinical manifestation, like I said, these kids present healthy at birth. They look pretty good in their normal birth weight usually. Symptoms usually develop though in the first 2 to 6 weeks of age. They usually present with jaundice or acolic stools, also known as white stools. I will try for the adults to do my best to discuss the peds portions more, but they also will have poor growth, pruritus or itching. They can even present with portal hypertension and end-stage liver disease with ascites and varices and hepatosplenomegaly. They look good until they don't. That's one of the things we're always taught in pediatrics is they look good until they don't, and so you want to catch them before then. Liver biopsy has a pretty high diagnostic accuracy. You can see there, they usually have a normal hepatic architecture with bile duct proliferation, bile plugs, and periportal fibrosis. I don't know if you can see my marker there, but this is a bile plug. We have some bile duct proliferation on this side here. And so this is kind of a classic liver biopsy finding. It leads us in that direction, but it's not, doesn't say 100% this is biliary atresia. The next thing you have to end up doing is a cholangiogram. These can be by IR or intra-out. Most of the places I have worked at and most of the surgeons I've worked with prefer an intra-out cholangiogram because then they're already in there and can go ahead and do the surgical Kasai afterwards. If you look here though, this is an intra-out cholangiogram. This one's actually normal. This is not one of biliary atresia. When you look at this bottom picture, this shows the intrahepatic bile ducts very nicely. When you have biliary atresia, you won't see this contrast going through the smaller ducts and looking like a tree. I didn't show that one just because there's really not much to see. So treatment for biliary atresia, early diagnosis is extremely critical. These kids all require a surgical procedure called the Kasai portoenterostomy, and that's it hopes to restore the bile flow. Best outcomes if it's performed before 3 months of age. If you look in England where they've narrowed this down to where they only have 3 surgeons doing the surgical Kasai, they actually say they have better outcomes if it's less than 60 days of age rather than 90 days. They also seem to get the kids referred a little sooner and picked up a little sooner by being only 3 centers that treat biliary atresia. The goal of the Kasai is to help prevent rapid progression of liver injury and development of cirrhosis. Now, most people do not consider this an actual curative treatment, but more of a palliative treatment. But there are some good outcomes if you do have bile flow within the first 3 months. The problem is most people don't normalize their labs. Here's a picture of a Kasai portoenterostomy with Dr. Rodriguez on the phone. He could explain this a lot better than me, but I'll do my best, Manuel. So what a Kasai enterostomy is where you actually go through and you dig out some of the bile, the liver until you get to free-flowing bile is the goal, and then you bring up a portion of the intestines to drain the bile out of the liver since the bile ducts are fibrotic and not working. 75 to 90% 10-year transplant-free survival if your jaundice clears by 3 months post-Kasai. Now, this is not the norm, unfortunately. Only about 40% will completely clear by 3 months of age, and not all of those will go on to have 10 years transplant-free survival. If you do not clear your jaundice or your cholestasis within the first 3 months after your Kasai, you only have about a 20% chance of having a 3-year transplant-free survival rate. More than 50% of kids with biliary atresia get transplanted by 2 years of age. And so the goal is if to go ahead and do an earlier transplant before they become cirrhotic and malnourished if they do not clear their bilirubin within the first 3 months post-Kasai. So most centers will say trying to get them evaluated between 6 and 9 months of age, or for sure by a year. Because liver transplant is one of the treatments for this, I have to do a little plug on pediatric liver transplant. This is UNOS numbers as a whole. You can see there that deceased donors is increasing every single year for the last 10 years and a 6% increase over 2019 with more than 33,000 transplants. Kind of looking at the wait list stuff for liver transplant, this was updated as of May of this year. You can see in the pediatric group, we had a little dip in 2020 for transplants due to COVID with only 502, but on average are about 550 pediatric transplants a year, which is completely different than the adults where they sit somewhere between, around 9,000 or so. But you can also see with the adults that we still do majority of a deceased donor, and we have not increased our living donor yet like other countries around the world have. Patient survival is overall pretty good. We'll go into pediatric survival, which is even better than this 1 and 3 year survival that you see down here. This includes adults. So this is just the pediatric numbers. This is the number of patients that were added to the wait list or wait list candidates. And all of this is from the SRTR annual data report and from 2018. And you can see we add about 700 patients or have about 700 patients a year on the list. This is looking at it by age. So you can see there that about 25% or so are less than a year of age that are listed for transplant. And then we have an increase over the last 5 or 6 years for the ages 1 through 5. And that also goes where a big chunk of those are patients with biliary atresia. This is looking at it by race, where the majority are Caucasian, only about 12 to 15% are Black, Hispanics are a little over 20%, and the Asian population is less than 10% who are listed for transplant. When you look at donor type, the majority of pediatric transplants are deceased donor as well, and you see down there the living donor as well, less than 100. This is something we need to work on. We should have no patient deaths in pediatrics if we can utilize our living donors appropriately. In other countries, living donor is the only option or the first option, not deceased. And so I am working with Dr. Manuel Rodriguez and some other docs on trying to increase our living donor in pediatrics. They have just as good of outcomes as the deceased donors, and this is a great area that we can expand on to improve our outcomes and decrease waitlist deaths for pediatrics. This is survival. If you look over there at the y-axis, you can see that the percentage is 86% is our bottom number there. And if you look at all transplants as a whole, our overall is greater than 88% survival. Now this is 5-year survival, and it only goes from patients that were transplanted between 2009 to 2013, and those numbers are improving every day. But you can see we have great outcomes and great survival. So now back to some of the more common liver diseases. Alagille is another common one that we see, and it's also one of the ones that's part of the cholestatic. We always think of when we get that yellow baby, biliary atresia comes to mind, Alagille comes to mind. PFIC is also one of the ones, which we won't talk about PFIC tonight. Alagille syndrome, though, is an autosomal dominant multi-system disorder defined by Notch signaling dysfunction. Majority of the time, liver disease does not develop outside of early childhood. So you're going to know by 2 or 3 years of age if the patient's going to have liver disease and how severe. Kids with mild liver disease actually may improve as they get older. Alagille is caused by various mutations in the JAG1 gene and the Notch2. JAG1 mutations account for more than 90% of the diagnosis, but Notch2 we're starting to see more of. There was a recent study in the last couple of years out of CHOP trying to look at all of the mutations and the missense mutations and trying to better identify those, and we're identifying new mutations all the time. There is variable phenotypic penetrance. There's no correlations between the genotype and the phenotype, even in the same families with the same mutations. You may have one person with a lot worse liver disease or kidney disease and someone else with very mild. The incidence is about 1 in 30,000 to 1 in 50,000 live births. So not as common as biliary atresia, not super common, but still fairly common for pediatrics. Clinical manifestations. Bile duct paucity on liver biopsy is an important one, and this is where the biopsy is important when we're looking at a kid that presents with cholestasis or jaundice. Bile duct proliferation and bile plugs makes you think more of biliary atresia, but bile duct paucity is what makes you think more of Alagille. However, on a biopsy for Alagille, you can still have giant cell hepatitis and bile duct proliferation, and so it can sometimes get confused and lean you towards biliary atresia when it's actually Alagille syndrome. These kids also present with jaundice, pruritus. They can't get the bile acids out, and so that leads to significant itching. That might be one of the worst causes, which is what our friends who are hosting us tonight are working on. Xanthomas is another one due to the significantly elevated cholesterol. Those usually improve over time, the cholesterol does, and so the xanthomas go down as the kids get older, but there's no treatment for the xanthomas. And they're not painful, but they do cause people some concern from a body image standpoint. These kids will also have poor growth. They're overall smaller than their peers of their same age. They can have renal anomalies, developmental delays. And then, of course, the things we know Alagille for is congenital cardiac disease, vascular anomalies, ocular abnormalities, skeletal abnormalities, and the typical facies with the triangle facies, deep set eyes, prominent forehead, and the pointed chin. Diagnosis, we now can do a molecular diagnosis or genetic diagnosis if there are no mutations, but this is one of the diseases we still have an option for clinical diagnosis. And the way to diagnose it clinically is if you have bile duct paucity on liver biopsy, and then 3 of the 5 major clinical features. So cholestasis being one of them, ocular abnormalities, the most common being the posterior embryotoxin, the characteristic facial features like we just previously discussed, any cardiac defects, but peripheral pulmonary stenosis is again most common. And then skeletal abnormalities, which the most common is butterfly vertebrae. So it's one of the few that we can still do a clinical diagnosis, but we are making a lot more stride in the genetic side. This is also looking at the histology. So if you see, comparing the adult liver to the Alagille liver, you can see where it says the PV is the portal vein, the HA is hepatic artery, and the BD is bile ducts. When you look at the Alagille biopsy, this is a portal triad, and you see the portal vein, the hepatic artery, but you don't find a bile duct right there. That cystic opening is more, is bile duct paucity than actual bile duct. So this is one of the main features on biopsy. Unfortunately, we don't have any great treatments. Everything is symptomatic management. Pruritus is always our toughest one. We don't have any drugs that do great. You can use ursodiol, cholestyramine. You can use, some of your Atarax and Benadryl at night to try and help them sleep. But none of these things are great. And this is where they're trying to use the IBAT inhibitors that are coming down the pipeline of trying to do bile acid transport inhibition so that you don't take up the bile acids in the ileum and that you can actually have less bile acid pool, which would hopefully improve pruritus. And that's what a lot of the studies are showing. You got to make sure you supplement for fat soluble vitamin deficiencies. These things need to be checked regularly. Many of these kids are deficient in vitamin A, D, E, and even coagulopathic at times with vitamin K deficiency. Growth is extremely important. These kids are small to begin with Alagille, but they should still be growing along their growth curve. And so trying to make sure we're giving them enough calories that they can grow, especially when they have significant pruritus and that's interfering with their everyday life. About 20 to 30% will go on to require liver transplant. You can see there the 1-year patient survival is about 80%. It's a little less than the overall transplant survival, but it goes along with the comorbidities of these patients. A transplant evaluation in the Alagille patient is a lot more detailed and because you have to evaluate cardiac status as well as renal status and make sure they don't need any interventions prior to listing. But both of those alone are not an automatic red flag to transplant. Alpha-1 antitrypsin deficiency is our next one we're going to talk about. It's an extremely common genetic disorder that's resulting in reduced levels of alpha-1 antitrypsin. It's usually caused by allele variants on the serapina1 gene. The wild type or the phenotype that most everyone has and that's normal is MM. Severe deficiency is known as ZZ, but there's over 100 different variants, allele variants, and a whole number combination that can cause liver disease and or lung disease. Alpha-1 antitrypsin is a protein that's produced in the liver and excreted into the blood, whose primary function is to protect the lungs from the enzyme neutrophil elastase. Neutrophil elastase's job is to clean up when there's injury and inflammation. However, it doesn't know when to stop. And so it's alpha-1 antitrypsin's job to actually stop the enzyme from auto-digesting the lungs. About 1 in 1,500 to 2,500 people are affected. When it presents in pediatrics, it presents more as liver disease. When it presents in adults, it's more lung disease with a COPD look to it. No matter what you have, if you have liver or lung disease, you should never be around anyone that smokes. So this is one that we do a lot of educations with our families. The liver disease is suspected to be caused by excessive amounts of alpha-1 antitrypsin that's trapped in the hepatocytes that can't get out because it's a misfolded protein that's made in the liver but can't exit the liver. Because of the excess alpha-1 there, it can cause progressive inflammation, and liver damage is noted in at least 10% of infants born with severe disease, and this can even lead to cirrhosis. So you can have an infant that presents with cholestatic cirrhotic liver disease within the first few months of life, requiring a liver transplant. It's rare, but it happens. Clinical manifestations of liver disease for alpha-1 antitrypsin in pediatrics, we see jaundice, poor growth, acolic stools, or the clay colored, the vomiting, the itching. Anytime there's a cholestatic liver disease with elevated bilirubin and buildup of bile acids, you get the pruritus or the itching. These kids have difficulty feeding, anorexia, and then signs of end-stage liver disease as well. Some kids, or many kids, I should say, go on, even if they have a severe phenotype, to have mild liver disease and can live a normal life with a healthy liver. But there is the 10% that do not. Testing and diagnosis is extremely easy. It's a simple blood test looking at alpha-1 antitrypsin phenotype. Some people still look at the level as well, but remember, if you have a kid that's sick, your level may be off. It is a elevated and inflammatory state. You can also diagnose it on biopsy, as you see these red dots here marked by the arrows in the liver biopsy. So this is one that we can even see on biopsy. If we don't ask for the pathologist, usually will say, hey, have you thought of this? Again, there's no specific treatment for alpha-1 antitrypsin liver disease. Liver transplant is the treatment for severe progressive liver injury, the ongoing inflammatory process, but there is now enzyme replacement that's been approved for lung disease. This does not fix the liver part of it, but it does improve lung disease. And there is currently gene therapy that's being studied that would do gene replacement therapy. And so it would fix liver and lung. That's just not out yet. So if you're noticing a theme, we don't have a lot of great specific treatments for these liver diseases in pediatrics, and transplant becomes the option if they have progressive disease. Moving to a little bit of the older kids, autoimmune hepatitis is another one. The adults could probably teach me a lot more about this, but I'm going to give the pediatric version. So kind of an overview of autoimmune hepatitis. It is a chronic hepatocellular injury wherein the etiology is unclear. There's a lymphoplasmacytic infiltrate with interface hepatitis on the biopsy. We'll look at a biopsy a little bit later. You have a predominant ALT and AST elevation in your labs. And usually have positive autoantibodies and hypergammaglobulinemia. However, remember 20% of pediatric patients that present with autoimmune hepatitis have normal seromarkers. This is considered a global disease with an incidence of 0.3 to 4 cases per 100,000 children. Prevalence is 16.9 cases per 100,000 persons per year. Females account for about 70% of the cases, with 50% of those being less than or equal to 40 years of age. So this does hit younger females. It is a cause of chronic liver disease in 11 to 23% of all chronic liver diseases, and it accounts for 2.6 and 5.9% of liver transplants in the Europe and US respectively. So not a big majority of liver transplants, but in pediatrics, a lot of times these patients will present in liver failure. They don't present as early. They present in a sicker phase than most of the adults do when they present. Pathogenesis, there's thought to be genetic factors with the antigen presentation and immunocyte activation, the DRB1 encoding for MHCA2 antigen binding grooves. You can also have triggering factors. We see this with the medications with minocycline with our kids with acne a lot. We'll see it trigger autoimmune hepatitis response. You can also see it with infections. We see at least one case every few years from someone that gets the flu and then has an autoimmune hepatitis picture. That's usually in the younger kids, and then also toxins and molecular mimicry. Up to 45% of patients with autoimmune hepatitis are diagnosed with concurrent immune-mediated illness. Here are the most common ones that they're diagnosed with celiac, autoimmune thyroid disease, and IBD and PSC. But here's all the ones that can be related or to autoimmune hepatitis. So you can see on there, there's a significant number, and especially with diabetes as well. Clinical manifestations similar to end-stage liver disease, since many of our pediatric patients present with a more advanced course, that they have fatigue, they can have fever, but usually jaundice, anorexia, hepatosplenomegaly, they may get the spider angiomata, kind of some cushingoid features, acne. But like I said, they can present as an end-stage liver disease with portal hypertension, ascites, varices, and encephalopathy, or as acute liver failure. We even have some that will present with hepatocellular carcinoma, HCC, in a more advanced state. Or, like I mentioned, completely asymptomatic, and as 20% of our kids have negative serum markers. Those are criteria for trying to say probable versus definitive autoimmune hepatitis. And this is the simplified criteria from the International Autoimmune Hepatitis Group. So looking at there, you can kind of give a score. 6 is, or a score of 6, excuse me, is considered probable for autoimmune hepatitis. A score of 7 or above is considered definitive for autoimmune hepatitis. One of the things you need to make sure you rule out though is any viral hepatitis. Histology, there's a lot more details with this than the previous ones we've discussed. You can have interface hepatitis, some inflammation or collapse in the panacenar, lymphoplasmacytic infiltrate like we talked about. You can even see eosinophils, rosette formation, or they can present with end stage with fibrosis or cirrhosis. So here's looking at a few of the different things. On this bottom right, we can see that we have interface hepatitis. There's not a clean line here, which is what you should see around a portal triad. We also have plasmacytic infiltrate, and we even have some EOs in here in this one. So we have a variety of what you can see, and these were stained differently to notice the different cells. We don't usually do all of these stainings for one liver biopsy. Usually an H&E would be enough to teach you what you need to know. And these are pictures courtesy of Dr. Helene up in Chicago. So goals of treatment for autoimmune hepatitis. Your goal is always to induce remission if possible. You want to prevent the disease progression, minimize relapse of disease, and minimize medication side effects to improve overall transplant-free survival. One of the things that we do in pediatrics very often is we actually try and do treatment withdrawal, where they've been on steroids for quite some time. If labs are normal, biopsy looks normal, pull those off, and then after a couple of years, even try and pull off their 6-MP or azathioprine or Celsep, whichever medication that they're on. So with that in peds, we do see relapse after treatment withdrawal. You can see treatment failure, incomplete response, or even drug toxicity. Disease remission is where you get disappearance of all the symptoms, normalization or near normalization of your labs, minimal or no hepatic inflammation on biopsy. And you can see this in 65 and 80% of patients within 18 months and 3 years of initiation of treatment, respectively. 10-year survival is about 90%. First-line treatment is always steroids and usually 6-MP or azathioprine with Celsep not far behind it. But there are multiple other drugs that we won't go into detail with. Relapse after drug withdrawal is always frustrating, but it's something that we do see. Your ALT and AST go up, get significantly elevated. Your IgG or gamma globulins increase. You get recurrence of inflammation on your liver biopsy. There is a 50% chance of relapse at 6 months and 70% at 3 years off of medication. So the question always becomes, well, what do we do if we relapse? So as we're discussing this with pediatrics, the parents always ask me, well, what happens if it comes back? Is it going to work to retreat? The answer is yes. We use the exact same regimen for relapses as we do for a naive patient. Long-term low-dose prednisone and then azathioprine or 6-MP. 47% of patients will achieve sustained remission off of medications after 10 years, even with a relapse. So it's pretty good outcomes. Of course, there are the treatment failures where you have worsening symptoms. It's only about less than 10% of patients, but you get a progressive necroinflammatory activity and even on signs of liver failure. There are a few different meds that people will try for high-dose immunosuppressive therapy, but ultimately, if you have treatment failure with worsening liver failure, your option is going to be liver transplant. We kind of talk about this here, but liver transplant in pediatrics is what usually happens. Drug toxicity is another problem with all these medications. Some people have intolerable symptoms or develop obesity, osteoporosis, and fractures. Remember, we're dealing with pediatrics. We have a lifelong ahead of us. We have developing bones, so trying to make sure we're staying on top of keeping healthy bones and good nutrition so that we avoid long-term osteoporosis or even short-term fractures. Diabetes, we can see cytopenias from cell lines, all cell lines down from cell death, but also from 6-MP. Azathioprine-induced hepatotoxicity. This is always one that's, we have to make sure we discuss in detail with families when we're getting ready to start the medication that yes, in and of itself, it can cause hepatotoxicity. It's rare, but it's the treatment of choice. And then we go through, if something causes toxicity, what are our options? Reduction, withdrawal, or even changing of the medications. These are also part of the reasons we try and get pediatric patients off of medications as soon as possible, as long as their liver biopsy looks good and they have normal numbers. So kind of the take-home points, it is a chronic hepatocellular disease of unknown etiology. The clinical presentation is variable. Diagnosis is based on liver enzymes, your AST and ALT, your serologies, your IgG, and your histology. Currently, immunosuppressive therapy is the mainstay of treatment with great response and even ability to get kids off of treatment. And then we also are trying to tailor therapy based on treatment endpoints and based on the individual patient. So, but in the end, if they do have progressive disease, liver transplant. We're going to spend just a few extra minutes on non-alcoholic fatty liver disease, since this is the #1 pediatric liver disease, cause of liver disease. We're going to talk about in a little more detail. This next set of slides were part of the Speaker Bureau fatty liver disease from NASPGHAN that we put out a couple of years ago that I was a part of. But just kind of giving you the big picture, most of you guys know this, but NAFLD is an umbrella. It includes your non-alcoholic fatty liver without the D, which is just bland steatosis, your non-alcoholic steatohepatitis, where you have inflammation in your fat. It includes your non-alcoholic fatty liver disease with fibrosis and or cirrhosis. Pediatric fatty liver disease looks a little different on biopsy than it does on the adult side. We'll kind of go over that in just a minute. But the overall basic terminology is NAFLD is fatty infiltration of the liver by more than 5% based on imaging or histology without significant alcohol intake, genetic disease, or medications that cause steatosis. Looking at the spectrum of pediatric non-alcoholic fatty liver disease in the NASH Clinical Research Network, if you look at this included 176 children from 8 clinical sites. And now this one is several years ago. We haven't done the updated, they're working on the updated one, I should say. But about 80% of these kids had NASH based on biopsy. And if you look, 30% of them had significant fibrosis. And these kids are 6 to 17 years of age. It's always difficult when you see that 7, 8, 9-year-old do biopsy and concern for NASH and find out they have bridging fibrosis or even cirrhosis. The majority of these kids had BMI percentile around the 99th percentile. You can see there the mean BMI of 33. Remember, the percentiles are a little different on peds, and we don't go just by the BMI, we go by the percentile. Other clinical features associated with more severe pediatric NASH is abdominal obesity or increased waist circumference, insulin resistance with prediabetes or diabetes. Hispanics have the highest risk. There's also genetic polymorphisms with PNPLA3, increasing age. So around that peripubertal and postpubertal age is when you see it the worst. There is some studies that are being done and currently some unpublished that are showing that African-American females that are actually protected usually from NAFLD once they're go through puberty and on into adult can have NAFLD pre-puberty. And so something must take place during the pubertal years with the hormonal changes. If you have an ALT greater than 80 plus an elevated AST and GGT, higher risk, and then of course dyslipidemia, it's higher risk for more severe pediatric NASH. The future implication, NASH-related cirrhosis in the United States alone has increased 6-fold over the last decades in adults. It's now the second leading cause for liver transplant in adults. I hear it's going to be the #1 fairly soon, if not already. It is the most rapidly growing indication for liver transplant-related hepatocellular carcinoma. So even though we don't have long-term outcome for kids yet, we know that the trends in adults are very worrisome, and pediatric patients are probably not far behind, and they have an even longer life to live. So we've got to figure out what's going on and how to treat it and stop it. So looking at the prevalence in children, NAFLD is the most common cause of pediatric liver disease, like I said at this a little bit ago. There are currently no studies describing the incidence of NAFLD in children. The prevalence does parallel the obesity epidemic, and we've seen a 2.7-fold increase in obesity in pediatrics from the 1980s to the current era. So the prevalence does vary with the age, gender, race, ethnicity, and the BMI. There is an increased prevalence in NAFLD in children with certain risk factors such as prediabetes, diabetes, obstructive sleep apnea, and hypopituitarism. And the prevalence depends on the population being screened. Are we looking at the general population or more the high risk? Are we looking at just the patients with obesity or those that come from families with obesity? Our screening methods are not ideal at this point. And the main ones used are ALT, imaging, and liver biopsy, but we'll kind of talk about the downfall of each of those in just a minute. If you look at the prevalence in kids in the ages of 2 to 4 years of age, it's 0.7%. 15 to 19 years of age is already above 15%. And then if you're looking at obese children with an elevated ALT, you can see there it's 30 to almost 40% of kids that will have NAFLD. There is a fourfold increased risk for Hispanic children ages 11 to 22 years, and this is our highest risk population. Asians are a little bit further behind at 10.2%, with white children at 8.6%. But like we talked about, Black children are more protected, or at least they are as adults, but we're starting to identify it more in pediatrics with some of the studies that are ongoing right now. Children with type 2 diabetes had almost a 50% prevalence of elevated ALT. Obstructive sleep apnea is associated with NASH, and independently of what the BMI is and standard metabolic risk factors. We're noticing that obstructive sleep apnea has an effect on liver disease as a whole, not just fatty liver disease, but even in our transplant patients. And children with hypopituitarism have an increased risk of NAFLD and NASH and even cirrhosis. So kind of summarizing everything, the prevalence of pediatric non-alcoholic fatty liver disease is paralleling the growing prevalence of obesity in children. The prevalence does vary with the population screen, the level of risk, and the modality used to detect it. And then it is higher in certain subpopulations, specifically the overweight obese children, males more than females. Hispanics have the greatest risk in the setting of prediabetes or type 2 diabetes, obstructive sleep apnea, and then hypothalamic dysfunction. So there's always been a question of, is there a more aggressive phenotype in pediatric fatty liver disease? And this is a study, it's a small study, but it's looking at severely obese adults and adolescents at the time of bariatric surgery. So everyone's BMI was greater than 40, 24 in each group. So again, still small, but if you look at it, 63% of the adolescents have definitive NASH, where only a quarter of the adults did. And then 83% had the fibrosis with a mean fibrosis score of 1.3 compared to 0.4 in the kids. And so the NASH activity score is also more elevated. The NAS is also more elevated in these adolescents. So it's always been, questioning like, do they have more advanced disease than the comparable adults? And this is also worrisome because these kids are much younger and have a lifetime ahead of them. So how do we screen? Before we start talking about screening, we talked about how ours are less than ideal options and ALT is one of our main ones, but what is the actual upper limit for ALT? If you look at the different labs across the country, they use local populations to figure out norms. They don't exclude anyone with liver disease or overweight or obese. If you look at the median upper limit of normal for ALT at most children's hospitals, it ranges from 30 to 90. However, if you look at ALT in healthy weight, metabolically normal liver disease free kids from the NHANES adolescent group study, the 95th percentile for ALT is 26 for boys and 22 for girls. So this is what we use when we do pediatric studies, or as a pediatric hepatologist, these are my norms. Even if the lab says 50 or 60, I'm always educating families that 26 for boys and 22 for girls is what we use. There are limitations with ALT, as I alluded to earlier. There's a poor correlation with histologies. Some studies say that AST and GGT are better correlated with fibrosis, but that's still not panning out with pediatrics. And you can even see an ALT change with placebo. So a patient that's made no interventions and had no changes to their weight or BMI or even gained weight can have a change in their ALT. The ALT does fluctuate over time in general, and it can't differentiate between NASH or NAFL without a D. Ultrasound's another one that we always think about in pediatrics. It's non-invasive, which we love. We don't like to do invasive things in kids, but it's got a low sensitivity and specificity, especially when you're looking at lower degrees of steatosis. So this is not recommended as part of the screening guidelines for NAFLD that was set out by NASPGHAN a few years ago. Now, we do still use ultrasound in pediatrics with the person that presents with elevated liver enzymes of unknown etiology as ruling out other things such as tumors, masses, or vascular malformations. But we're not looking at it to diagnose fatty liver disease. Again, it can't differentiate between non-alcoholic steatohepatitis and just non-alcoholic fatty liver with bland steatosis. However, we still get a lot of reads or get a lot of kids sent to us as well that says, hey, they had fatty liver on their ultrasound. Can you see them even if they have normal ones? The current recommendations from the AAP guidelines are that we should be screening these kids between 9 and 11 years of age if it's a child with a BMI greater than the 95th percentile, or a child with a BMI in the 85th to 94th, which is considered the overweight group, with additional risk factors such as insulin resistance or pre-diabetes or sleep apnea or a family history of NAFLD or NASH. There is discussion that earlier screening should be considered in younger patients with risk factors such as severe obesity or a family history, or of course the hypopituitarism, as we talked about, they can go on to have cirrhosis. And then even screening of siblings and parents of children with NAFLD if they have known risk factors. The question always becomes is how do we do, if I'm seeing the pediatric patient, how do I discuss this with the parents if they look like they likely could have, or have risk factors for NAFLD sitting in my own clinic office? Or what do you do if you're the adult hepatologist working with the adult and you haven't seen the kids, but you hear about that one of the parents mentions that their child is overweight? How do you educate them and talk to them about kind of the risk for all the family members, not just the patient you're seeing? Currently, our best test is ALT. It's not ideal, as we talked about. We talked about the upper limits of 22 for boys or 22 for girls, excuse me, and 26 for boys. If it's persistently elevated for more than 3 months and twice the upper limit, we need to evaluate these kids for NAFLD, which is a guarantee in pediatric, not a guarantee, I should say, but it's very highly likely they're going to get referred for further workup. And then an ALT greater than 30, an ALT greater than 80 warrants increased clinical concern and timely evaluation. What is different in pediatric NAFLD compared to adult is we can see numbers of ALT of 300 and 400. Now, my first thought in them is not just this is NAFLD. I'm going to be making sure I'm rolling out autoimmune hepatitis, Wilson's disease, all the other potential underlying liver diseases that I have other treatments for. But we do see enzyme levels that high, which is not what you normally see in the adult population. Like we said, ultrasound is not recommended as a screening test, but follow-up screening is recommended by repeating the ALT every 2 to 3 years if risk factors remain unchanged, or consider repeating them sooner if the clinical risk factors change. We a lot of times will see these kids back in our clinic every 3 to 6 months, depending on what site you're at. I feel like we're their biggest cheerleaders, so trying to root them on. I don't have a true treatment for them, but we have a dietitian, multiple dietitians that work in our clinic that meet with these families and try and do dietary interventions. Fatty liver disease is a diagnosis of exclusion. This is kind of a chart of looking at a lot of the other things that we need to exclude first before we just say it's fatty liver disease. We also will use liver biopsy can weigh in on this. We talked about the serum markers and scores that aren't the greatest. Imaging modalities aren't recommended unless you have MRI, PDFF, or something like that. And then the liver biopsy, which is invasive. So this is looking at the histology of non-alcoholic fatty liver disease in pediatric patients that we don't see in adults. So the pediatric pattern, which is different, is we actually have portal inflammation and we don't see the ballooned hepatocytes. You can have portal and periportal fibrosis. Zone 3, centered injury, is more the adult pattern, whereas it's more zone 1 in the pediatric patients. And you see sinusoidal fibrosis in the adults versus the portal and periportal fibrosis in pediatrics. So it is, on biopsy, looks like a different disease. And the question is, should we be treating it differently? Unfortunately, we don't have any great treatment options at this time. Our goals of treatment are always regression of the disease, defined as decreasing the steatosis, the inflammation, or the fibrosis, or even resolution, which is determined by liver histology. Other treatment goals is you want to improve the dyslipidemia, any insulin resistance, blood pressure, and of course, decreasing their adiposity. Our current treatment options in pediatric are lifestyle and dietary modifications. We focus a lot on this in the clinic side. Lifestyle modifications is our first line approach to all of these kids. That's why we have dietitians meet with the majority of the patients, if not all, to kind of go over a more detailed history. With the times that we live in, not all kids can just go outside and play, and with parents sometimes having to work 2 and even 3 jobs, we have to get creative on how we get them to do physical activity. Thankfully, YouTube is around and there's a lot of exercise videos, and most of these kids have access to YouTube, and so we try and encourage exercise activities by videos off of YouTube. They don't have that, trying to get creative with how they do walking in the house or what activities they can do in the house. We try and avoid sugar sweetened beverages, looking at a well-balanced diet. Pediatric patients don't always have the best diet. And then with all the food insecurities and food deserts, this has become even more difficult. This was brought to light even more so than we were already aware of when the COVID hit and everyone was staying at home and our kids were not going to school. A lot of our kids are getting the free breakfast and free lunch at school, and then part of the Backpack Buddy Club where they get a backpack sent home full of food on the weekend. Once COVID hit and they were doing virtual schooling, they were not provided all of these meals, and families were having difficulty trying to obtain enough food to be able to provide for their family. We talk about moderate to vigorous exercise, getting our kids motivated to actually do exercise. I still have one of my favorite patients that he only walks on the treadmill at a speed of 1.5. So trying to get him at a higher speed. As an active 12-year-old, he can absolutely do a faster speed, but that's what he chooses at this time. And then the screen time. You see all these kids, most kids have phones or iPads or even computers at home, or their tablets that are sent home with them from school. So trying to limit their screen time to less than 2 hours per day. Before the pandemic hit, we were saying limiting screen time to less than 2 hours. That should also include the hours that you're on it for school. Of course, with virtual schooling, that became a little different setup. So now we're trying to figure out how to get these kids active and not just sitting on their tablets and phones all day. We don't currently have any medications available or supplements to treat NAFLD in pediatrics. Bariatric surgery may still be considered for selected adolescents that have non-cirrhotic NAFLD, the BMI, and absence of other serious comorbidities. We do refer occasional patients for bariatric surgery, but it's not near as common like it is in the adult population. So that was the fast fly through pediatric liver diseases, some of the more common ones. I know the adults usually don't see all of these like we do, and also kind of talk about the difference in fatty liver compared to adult. So I hope I didn't go too fast. I was trying to get us back on time, but let me know if you have any questions. I'm happy to answer anything. Kathy, I think you can take this screen back now and become host.
Yeah, thank you so much. I am. in the process of doing that. And then I was going to move us to a gallery view so that if anyone had questions, they could certainly ask. I think there was something in the chat there for you, Dr. Mavis.
Manuel mentioned renal diseases and Alagille syndrome. We see multiple different renal diseases in Alagille. I've had one that's had FSGS. We see some of the renal tubulopathies that we can also see. So there's, and even just some with having more chronic kidney injury that we can see with Alagille. And so it's one of the things we watch a lot closer. We don't see as much kidney injury in the young kids as we do in some of the older ones, but it is something to always consider. And you will have some kids that present with worse renal disease than they do with liver disease. So that's a great question.
Wonderful. You're welcome to take yourself off mute if you want to have a conversation. I see that there's a party in Utah over there in Dr. Rodriguez's office. So certainly feel free to join in the conversation. Good to see you.
Thanks for joining.
Thank you. Great talk, Alisha. Yes, we really enjoyed it. We have some of our fellows and students here. So thank you so much for you're raising the bar, so we have to do the same thing now on the West Coast.
Well, let me know when you do, and I'll listen in.
Different, right? Something different, but thank you for having us be part. And I think that part of what the American Liver Foundation has done is being able to connect us through the different regions. And so we look forward to working, Kathy, with you guys in any programs that you organize.
Yes, it'll be our pleasure.
Especially, I think that one thing we've done a lot of things with the adult programs here, but I think for pediatrics, because of the limited numbers, we still don't have as much. So I think we have to think that something that we've all learned through COVID is that we can be closer with these Zoom talks. So I think especially for pediatric topics, this is fantastic that we're able to, to kind of share knowledge and experience. So thanks, and thanks, Alisha. Great talk.
Thank you. Oh, I see in the chat that Leslie brought up MAFLD, MAFLD versus NAFLD, which is now becoming a hot topic. The MAFLD is metabolic associated fatty liver disease versus just non-alcoholic fatty liver disease, and looking at it more as the metabolic syndrome. This has taken hold a lot more on the adult side, but we're starting to look at it in the pediatric side. We didn't always think of metabolic syndrome on the ped side, but we're starting to see more and more of that as we're seeing the type 2 diabetes with the fatty liver disease, the obesity, and all the other comorbidities that come with that. So that's a great point. Thanks, Leslie. By the way, that's one of our fabulous dietitians that works with us in our fatty liver program.
And I think you may have seen Dr. Rodriguez's comment about mentioning renal disease and AGS.
Yeah, that's what we just went over. That's the Alagille.
Right. Okay, gotcha. Wonderful. So if anyone has any other questions, certainly feel free to bring them forward to Dr. Mavis. I don't want to cut us short.
And you're always more than welcome to email me too if you have questions afterwards.
Great, so I'm going to go back to screen sharing here, and certainly, take a moment to, oops, oh, I've got a long way to go here to get back to, stop for a second so I don't get you all seasick. So I will just end with us being on this full screen here. Thank you very much, Dr. Mavis, for that informative presentation on pediatric liver disease. And no doubt, despite the fact that the topic was pediatric liver disease, I'm sure that the information will be helpful to the healthcare professionals who treat pediatric or adult liver patients. So thank you for that. As always, we encourage everyone to follow the American Liver Foundation on social media. Remember that we recently added a YouTube channel dedicated to medical professional education. So please visit and subscribe to that. And to anyone who's visiting tonight, if you are not a member of one of our 18 medical advisory councils across the country, certainly contact me or Dr. Viana or Dr. Mavis, and we will connect you with the group in your part of the world. In closing, again, I wish to thank Dr. Mavis as well as our meeting sponsor, Albireo, and Deb and Emily, thank you for joining us this evening. We hope to see everyone at our fall MAC meetings in October. We'll be meeting on October 13th and December 9th. Dr. Keaveney is speaking on October 13th, and the speaker for December 9th is to be determined. So if anyone from our MAC has suggestions, certainly bring those forward. For now, please save those dates and keep an eye on your inbox for calendar invitations. Until our next meeting, thank you. Stay safe and well. And again, thank you so much, Dr. Mavis.
Thank you, everyone. Good night.
Good night.